We can use.
Okay. If you think of a healthy patient or individual who's not having surgery, why would they require fluids? Why would they drink liquids? Are they going to respond to me, or should I just go on?
No, I think they will not respond. You can, if you want, you can ask questions from us, or we can ask questions from registrars. Even registrars are slow to respond. So if you want a fast answer, you can ask one of us.
Okay. So why do we drink? Eat and drink mostly. How does it help with the physiology?
So we want to maintain our normal homeostasis of the body.
Yeah.
So without that, the body fluid, without this body fluid appropriate compositions, we won't be able to function normally.
Yeah.
So
you need to maintain the composition and the concentration of various body fluid compartments. Right? So if you take healthy adult, about 60-20% of body weight is water, and the water is distributed in the different fluid compartments. Intracellular compartment has the biggest fraction of body water. That's about 2/3 of the total body, and 1/3 in the extracellular compartment. And out of that, in the extracellular compartment, about 75% is in the interstitial fluid compartment, and only about 25% in intravascular compartment. Right? So there is a constant shift of fluids between these different compartments, and the movement of fluid from the intravascular compartment in the interstitial compartment depends on Starling's forces. Right? So Starling's forces were used to explain this fluid shift, but now lot of new findings and about fluid movement and Starling's forces will probably go out of fashion very soon. For the moment, we'll stick to Starling's forces. So the shift of movement of between the interstitial compartment and the intracellular compartment depends on differences in osmolarity between the two compartments. So if there is a drop in osmolarity in the interstitial compartment, fluid will move from the interstitial compartment into the interstitial compartment. If there is a drop in osmolarity in the interstitial compartment, fluid will move from the interstitial compartment into the intracellular compartment, and vice versa. So this fluid movement is the fluid moves between compartments based on Starling's forces and the osmolarity.
Right. Okay.
So in the perioperative period, these Starling's forces as well as osmolarity would change, and that will affect the cellular function, because blood flow is important to carry oxygen and nutrients to the cells, but it doesn't do that directly. It carries them to the capillaries, where the exchange occurs between the intravascular compartment and the interstitial compartment, and then in the there is an exchange between the interstitial compartment and the intracellular compartment, and that way the oxygen moves into the cells, carbon dioxide moves out, and nutrition moves in, while the waste products come out. So for this to be maintained and for the cells to survive, this internal environment has to be kept constant. The tissues have to be perfused, oxygenated, nutrition provided, and waste products removed. So this is why, in very simple terms, this is why we need to maintain the body fluid compartment composition constant. Right?
Could you explain about this Starling process a little?
Yeah, Arun, I think the medical students is there. I think he can log in now. He can log in because now already 300 students have come, so I don't think he can log in now.
Oh dear.
So we'll continue like this, no?
Okay, so that Aruna?
Yeah, shall we talk about stalling forces? So that's some very basics.
Yeah. So Starling's forces are used to explain the movement of fluid between water, specifically between the intravascular compartment and the interstitial compartment. Right? So the movement of water depends on the presence of a filtration pressure. The forces that push water from the capillary into the interstitial space will be the capillary hydrostatic pressure and the interstitial oncotic pressure. Those are the forces that push water or draw in water into the interstitial space. Then the forces oppose this movement from the intravascular compartment into the interstitial compartment are the oncotic pressures in the intravascular compartment and the hydrostatic pressure in the interstitial compartment. Right? So depending on the balance between these two forces that push water and oppose the movement of water, there will be a net filtration or net absorption of fluid into capillaries. In addition, there is an important factor which is the capillary permeability. That changes from organ to organ depending on the primary function of the organ. For example, muscle cell, the net movement is into the interstitium from the intravascular compartment. But in the sorry, in the kidneys, again the net movement is from the capillaries into the interstitium of the Bowman's capsule and into the inner tubule. But in the lung, the net movement will be out of the alveoli into the intravascular compartment and into the lymphatics, because we don't want the lungs filling up with fluid. But in pathological states and also in the perioperative period, the capillary permeability can change due to the effects of various the inflammatory response, the toxins, the microorganisms. All these can affect this permeability. In addition, the startings for the hydrostatic pressures, the oncotic pressures also can change. So there is potential for derangement of this fluid exchange, right?
Okay, so Bhagya, as I understood from what you said was oncotic pressure is basically based on the proteins, right? Albumin.
Albumin, yes.
So that is the what I gathered are three things are important. One is the amount of protein that is there inside the cells and outside the cells.
Yeah.
And the pressure difference.
Hydrostatic pressure difference.
Yeah, so that is basically pressure difference inside the cells and the outside the cells.
No, sorry, no, not inside the cell and outside the cell. Not inside the capillary and outside the capillary. That is the interstitial space.
And the permeability. These are three things that are important for the fluid accumulation.
Fluids movement of fluid between the intravascular compartment and the interstitial compartment.
Right. So
why hydrostatic pressure at the capillary?
There is movement of water.
So no protein is filtered at the capillary level.
It depends. On the tissue, but mostly no proteins, right? But
so in pathological conditions, burns, inflammation, only protein leaks out of the capillary.
And especially in sepsis, where there is increased capillary permeability caused by the inflammatory mediators.
This is important that protein leaks out in pathological conditions.
Before going into fluid balance, how does surgery, how can Can it get affected during surgery, or can it change? Intraoperative.
Yeah. Now the main factor, or one of the main factors which affect fluid movement, the capillary hydrostatic pressure, can get affected or is determined by several factors. One is the intravascular volume. If the intravascular volume is low, the hydrostatic pressures will obviously be reduced. Then the inflow of fluid into the capillary and the outflow of fluid. Right? The outflow is, inflow is controlled by the precapillary sphincter or the arteriole, which is under sympathetic control. So if there is intense vasoconstriction because of sympathetic system activation, there will be reduced flow into the capillary. So the hydrostatic pressure will drop. Right? So filtration will drop. So these are things that can change in the perioperative period. For example, if a patient is in a lot of pain and the sympathetic nervous system is activated, that will cause constriction of the precapillary sphincter or the arteriole, and therefore the fluid movement into the capillary will reduce. So the hydrostatic pressure will drop and the fluid movement will reduce. Same thing is happening in shock, because in shock, the homeostatic or the regulatory mechanisms get activated, cause precapillary vasoconstriction. Right? It also can affect the fluid filtration in the kidney, because the afferent arteriole, the constriction of the relative constriction of the afferent and efferent arteriole will determine the pressure within the glomerulocapillaries. If the afferent arterioles are dilated and the efferent arterioles are constricted, the pressure inside the glomerulocapillaries will be high, so more fluid will get filtered. So this can be altered. This balance can get altered during the perioperative period.
In surgery, we talk about the third space losses. Is something to do with the impaired permeability or the alteration of permeability capillaries?
No, third space, actually, that concept is increasingly not believed. Third space, most of us don't consider third space losses now, because it's a very it's theoretical concept, and nobody knows where this third space has not been demonstrated. So if he say 1,000 milliliters of fluid got accumulated in third space, he should be able to demonstrate the third space. That is not demonstrated yet. So it is, but the third space is explained in terms of accumulation of fluid between cells, or in spaces like the peritoneal cavity, but the concept is not very clear. So we sometimes we were taught to calculate third space losses, but that's not really practiced anymore.
Okay.
So if we accept the third space, it is in the extracellular compartment.
Yes, extracellular compartment.
Right. Bhagya, now in normal individual, you said sort of there is ultrafiltration at the capillary level, no? So is there a net filtration out, or is it zero filtration at the end?
It depends on the tissue, but if you take the example that you take for a typical tissue is the muscle, skeletal muscle. In the muscle, there is at the arterial end of the capillary, the filtration pressures favor filtration into the interstitial space. In the venous end, the pressures favor reabsorption into the capillaries. But generally, the filtration is more than the reabsorption. Whatever is in excess will get carried away through the lymphatics.
Right. So there is a in muscles, you say sort of there is net filtration.
Upwards,
so that is carried away by the lymphatics, a different system back into the veins. Then Bhagya, how do we develop edema?
So depends. Edema due to can be due to overhydration, can be due to damage to the capillaries, can be due to obstruction of the lymphatics. So obstruction of the venous outflow, edema can be due to many reasons. So let's say if you take a patient who's got who's hypoproteinemic and the oncotic pressures are low, these patients, the net filtration pressure will be out of the capillaries, because the oncotic pressure within the capillary, which tends to draw in fluid into the capillary, is very low because the levels are very low. These patients will tend to develop or accumulate fluid in the interstitial space. So when the interstitial fluid, now the interstitial fluid volume increases progressively at the expense of the intravascular compartment. So the body senses that the intravascular compartment is depleted, and mechanisms which try to restore intravascular volume get activated, right? Mediated by the baroreceptors and the sympathetic nervous system. So in the kidneys, this will result in sodium retention because of the activation of the renin-angiotensin aldosterone axis, and retention of water because of the activation of the antidiuretic hormone. So more and more water gets reabsorbed into the intravascular compartment, but because the intravascular albumin concentration is low, that volume is not retained, and it will keep on leaking into the interstitial compartment. So it's an ongoing thing. It keeps on getting worse because the body mechanisms retain water, but in the hope of expanding the intravascular volume, but it doesn't happen because the oncotic pressure is low. So edema progressively gets worse.
So basically, edema is a pathological condition where you get excess fluid in the interstitial compartment, which may be due to lymphatic obstruction, which may be due to low proteins, or may be due to increased hydrostatic pressure.
Yes. Or increased capillary permeability.
Increased capillary permeability, like in inflammation. Right. Okay.
Now the problem with edema, if I can just expand on that. Now if you consider the movement of oxygen from the capillaries to the tissue cells, the diffusion takes place across the interstitial fluid compartment. Now when the interstitial compartment is full of fluid, the diffusion of oxygen from the capillaries to the cells is impaired. Same with the nutrition. So when you have more edema, the cellular function is deranged, primarily because of oxygen delivery deficiency and from nutrients. So when this happens, for example, you have a patient who's really hyperproteinemic because of malnutrition or whatever reason, and you give a lot of IV fluids, and the patient undergoes surgery, say for a bowel anastomosis, these the anastomotic healing doesn't occur as expected because there is not enough oxygen delivery to the site of injury. Right? So the chance of anastomotic breakdown will increase. Right?
So all this time we were talking about the environment around the cells, the importance of giving right amount of fluid in the microenvironment. But apart from that, are there any other important things in the not in the microenvironment, but in the circulatory system? Why it is important to give right amount of fluid? Not to overload or not to give less fluid.
If you think about the delivery of oxygen from the lungs to the capillaries, it depends on principally on 3 factors, right? It depends on, that's called the oxygen flux, and that depends on cardiac output, hemoglobin concentration, and saturation. Right? So if you just ignore the hemoglobin concentration and saturation for the moment, cardiac output depends on stroke volume and heart rate. The stroke volume depends on preload, contractility, and offload. So now in a patient who's euvolemic, whose intravascular volume is normal and is otherwise healthy, he will probably have a normal stroke volume, a normal heart rate and rhythm, a normal cardiac output. So in the presence of a normal hemoglobin and saturation, his tissue oxygen delivery is normal. in a patient who's hypovolemic, the cardiac preload is reduced, therefore stroke volume is reduced, cardiac output is reduced, and therefore tissue in delivery is impaired. So at a macro level, that's, I think, the best sample again give implications of hypovolemia. So when this is severe, we call that shock. Then there is inadequate tissue perfusion and oxygen to tissues.
So basically, hypovolemia means sort of reduced fluid in the intravascular compartment.
Hypovolemia is that, but
what is dehydration, Bhagya? Is it different to hypovolemia?
Dehydration is, we use it interchangeably, but dehydration, hypovolemia can be due to, say, blood loss. But dehydration, when we say dehydration, we generally mean dehydration due to loss of water from the cellular fluid spaces initially, and then loss of water from the other fluid compartment. So,
yes. So hypovolemia we use mainly fluid depletion in the vascular compartment, and dehydration there is depletion of fluid in other compartments as well.
But
it's easy to be treated.
It depends. So if a patient is hypovolemic, with progressive hypovolemia and delay in treatment, the compensatory mechanisms will initially get activated. So these compensatory mechanisms are mainly geared to maintain pressure, not volume. So if you think of the physiological mechanisms to maintain tissue perfusion, there are hardly any volume receptors in the body. All these receptors are pressure receptors. So the body tries to maintain pressure, sometimes even at the expense of tissue perfusion. Right? So activation of the sympathetic nervous system will cause vasoconstriction. This will restore pressures, but tissue perfusion is impaired. So if it's allowed to continue, these tissues which are hyperperfused because of capillary constriction, the cells will die. So initially, these compensating mechanisms try to divert blood to the vital organs by cutting off blood to the not so. But if it continues, then you reach the stage of irreversible shock, and the organism will die. So it is important to identify these patients who are hypovolemic or who are in shock or who are likely to move into shock, and start resuscitating them early and aggressively.
Aggressively with intravenous fluid.
Intravenous fluid.
Yeah.
It may be intravenous plus oral, but because oral is the most physiological and the best route to rehydrate patients. But if it's not possible, then IV.
Bhagya, you told about the problem in macro level. If you underhydrate a patient, cardiac output will drop. What will happen if you give more fluid? If you overhydrate, what will happen in macro level?
Yeah, so if you remember the Frank-Starling curve of the heart, right? You get the x-axis is cardiac preload, and y-axis is stroke volume. In the early part of the curve, or the ascending part of the curve, the preload is reduced. That is a hypovolemic patient. When you give fluid, you increase the preload, and you get the stroke volume and cardiac output is increased. But on the descending part of the limb on the Frank-Starling curve, if you give fluid, the stroke volume will drop. Right? That is because we say that the patient is fluid overloaded. The left ventricle cannot cope with this excess fluid. So when you have a patient in that part of the curve, the descending part of the Frank-Starling curve, giving more fluid will result in a reduction in stroke volume, which is not what you want. You want to increase the stroke volume. So the net result is a reduction in stroke volume, a reduction in cardiac output, and therefore reduction in tissue perfusion, and you're going to have cellular hypoxia, which is what happens in cardiogenic shock.
So basically, what you say is when they have low volume, Frank Starling curve. So when you give more fluid, the cardiac output increases up to a level. When you go beyond that, basically there will be heart failure.
Fluid.
The ventricles can't
fluid overload.
Fluid, right? Because it is so dilated, it can't give a good contractility. So it's a failing heart. So if you get a failing heart, either by reducing fluid, that will reducing preload will improve cardiac output, or you have to increase the contractility. So the things are with either you have to reduce preload, or you have to give inotropes.
Or vasodilators.
Always dilators. Okay, right. Understood. Thank you.
So up to now, what we discussed was we started with the importance of maintaining the fluid balance. Why it is important to maintain fluid balance, and then we spoke about Frank Starling forces, the three important things to decide where the fluid stays. And then we discussed about the changes that happens at the micro level, at the tissue level, and the changes that happens at macro level with regard to fluids. When you give more fluid, what will happen? When you give less fluid, what happens? So that's up to now. That's what we discussed. Anything else we discussed?
I think that's it. What about the pulmonary edema? They get due to excess fluids. That's due to heart failure again. Is it right heart failure or left heart failure?
Is because of increased movement of fluid from the pulmonary capillaries into the pulmonary interstitial space. And once fluid gets into the pulmonary interstitial space, there is hardly any barrier which prevents movement of fluid into the alveoli. There is no barrier because the alveolar epithelium is very thin, and there is a lot of space between these alveolar cells, so fluid just flows into the alveoli. Now the fluid will flow from the capillary into the interstitial space. Again, Starling's forces can be because of increased hydrostatic pressure, reduced oncotic pressure, or increased capillary permeability. So if you take pulmonary edema, we classify pulmonary edema into two groups: cardiogenic pulmonary edema and non-cardiogenic pulmonary edema, or ARDS. ARDS, or acute respiratory syndrome, is known as non-cardiogenic pulmonary edema. So this classification is based on the mechanism. If there is increased hydrostatic pressure in the capillaries, that usually occurs due to failure of the left side of the heart, maybe failure of the left atrium or left ventricle, and there is back pressure in the pulmonary veins, which is transmitted to the pulmonary capillaries. Pulmonary capillary hydrostatic pressure increases, and fluid moves into the interstitial space and the alveoli. So that is cardiogenic pulmonary edema. In non-cardiogenic pulmonary edema, there is no change in hydrostatic pressures. The left ventricle is normal, the left atrium is normal. Problem is in the capillary permeability. In ARDS, which follows sepsis, for example, the capillary endothelium is damaged by the inflammatory mediators. It increases permeability. In, say, somebody who gets COVID or some kind of severe pneumonia, the infection and the inflammatory response destroys the capillary permeability and the alveolar cells. So there is fluid movement into the alveoli. Again, there is edema, but there is no problem with the left side of the heart. So it's non-cardiogenic pulmonary edema.
Okay, Bhagya. Now you said the pre-operative fluid status of the patient is very important. Is it for the smooth? You said sort of there are certain problems if you have overloaded, or if the patient is underloaded also. So what are the now anyway these patients, usually we do operations in the morning. Even a normal individual doesn't drink or take fluids overnight. do we have to do anything in addition for a patient who is undergoing a major surgery to have ideal fluid status? And what is the ideal fluid status you expect for a patient undergoing major surgery? Is he little bit overloaded? Is he little bit hypolimic or isovolemic?
You are asking about before the surgery, right, sir? Not,
Yes,
not
pre-op.
Status.
Yeah, so ideally the patient should be euvolemic. He should be at the peak of the Frank-Starling curve.
Right.
So achieving it is a bit difficult, especially if the patient has to be kept fasting for fasting, right? So this is, which is why we encourage patients to drink clear liquids until up to 2 hours before surgery, because that's the patient's thirst is probably the best way to assess for the body to assess the need for fluids. So if a patient is hypovolemic, patient will feel thirsty, and patient will drink and maintain or restore euvolemia. The problem is when the patients cannot take orally, or patients are not allowed to take orally, then we have to try and guess how much fluid we need to give to maintain this euvolemic status. That's a bit difficult.
How do you guess this amount of fluid they need for the extra fasting hours? Is it based on their weight only?
Yeah. So we used to have these various formulae which to calculate the fluid requirement. For example, you would say patient will have insensible losses. That is to the respiratory tract and via sweat, which adds up to about 0.5 milliliters per kilogram per hour. And then we would say the patient's urine output is about 1 ml per kilogram per hour. So the total maintenance fluid requirement, or the fluid required to restore the losses in the urine and through sweat and the respiratory system is roughly about 1.5 milliliters per kilogram per hour. But again, this is a value that has been obtained from various experiments, may not be human experiments, may not be under the temperature that our patients are exposed to in the wards. So it's very difficult to calculate based on these formulae. And we are moving away from using these formulae. Similarly, third space losses, if the patient was having ascites, for example, we estimate, okay, this patient might have formed about 500 milliliters of ascites for 24 hours. So we place that also over 24 hours. Then there are, of course, measurable losses like in the drains, which we try to measure and replace. But this is a very, not a very accurate way of replacing the fluid that the body actually requires. So because of that, there are more recent or newer modern methods that are used to estimate fluid and to give fluid, especially during and after surgery.
So what you said was now before the surgery, what we are interested is to keep the patient euvolemic as much as possible, try to give normal maintenance, and to achieve that we try to keep them fasting as less time as possible and try to orally as much as possible. And there are different calculations that you use to calculate the maintenance, but that is not actually may not be the correct calculation. Now, is it important for all the surgeries? Are you like, what kind of surgeries are you worried about this pain, about the fluid balance? Subodh said major operations. Is it like how do you
if you have a patient who's coming for a hernia repair under spinal anesthesia, this patient can take oral liquids up to 2 hours before surgery. We stop giving fluids at 2 hours before surgery because we feel that if in case the patient needs general anesthesia for some reason, we need to reduce the risk of aspiration, and therefore we stop giving fluids at 2 hours prior to surgery. But this patient has minor surgery, can start oral liquids soon after. Therefore, we allow the patient to start drinking, and according to his requirement, he'll drink and also eat. So we really don't need to worry about this kind of patient too much, because they can control their fluid balance very well. Then you have the other patients who also need to be fasting. They have slightly more complex surgery, say like a laparoscopic cholecystectomy, elective surgery, minimally invasive, so the surgical stress is reduced. You have to keep them fasting up to 2 hours before surgery to reduce the risk of aspiration. But they can also start drinking. Most of these patients can start drinking when they are fully awake and when they are able to swallow. If the surgical team is happy, they can start drinking soon after surgery, as soon as they can protect the airway and prevent aspiration. So that should be the goal, to get the patient to maintain their fluid balance, because they are the ones who can do it best. Then you have the patient who comes to elective major surgery, like say a bowel resection or a liver resection. Those patients also can have clear liquids. They cannot have semi-solid solids because preparation, but they can have liquids before surgery, and then start giving them intravenous fluids operatively. And the aim should be to start them on oral liquids, at least small amounts, as soon as possible, with the aim of restoring normal oral feed in the shortest possible time.
Now, when we are fasting, we are not thirsty, we are hungry also. Fluids as well as calorie. That is why sort of we are hungry. These are considering in pre-operative patients also waiting for energy.
Yes. Like bowel preparation, you can give them glucose containing drinks, and I think you might have discussed this already. Enhanced recovery after surgery, they recommend a glucose containing drink, at least 40 to 50 grams of glucose 2 hours before surgery. So you can continue to give them calories right up to 2 hours of surgery. So that way, the advantage of this is the body switching to catabolic phase, be in the anabolic, the proteins post tissue is minimized if you can continue to feed them, at least give intravenous glucose right up surgery.
Okay, Bhagya. About enhanced recovery protocol. What exactly these protocols, and what are you going to achieve by implementing these enhanced recovery protocols, and which patients and which patients undergoing benefit by enhanced recovery protocols?
All enhanced recovery protocols. To, I guess, to minimize catabolism, minimize patient distress, minimize dehydration, hypovolemia, and it has been proved that patients on recovery protocols do better post-op. Their ICU stays sort of reduced, their length of hospital stay is reduced, and they feel better. Their well-being is they score better on well-being scores. And they're mobilized earlier.
Yeah.
So
Gut
heart
function starts
functions
earlier also.
starts earlier. Wound infections are less. So there are a whole host of benefits from these enhanced recovery protocols.
So there are
Definitely.
definite benefits for all forms of
Initially,
surgery.
they were used for colorectal surgery, extended to entire GI tract. Now even for Whipple's, liver resections, orthopedics, neurosurgery, these protocols are utilized.
Okay. Now for the benefit of our house officers as well as sort of medical students, what exactly we should do for a patient for anterior resection? We'll take for an example anterior resection, right? How do we implement enhanced recovery protocols in this patient?
Yeah.
Pre-operating.
Okay, so enhanced recovery protocols start in the pre-op clinic. So at the time when you make a decision to operate, just explaining the procedure to the patient, referring the patient to an anesthetic clinic, and getting an anesthetic assessment done, where anesthetist will speak to the patient about the plan for pain relief, where the patient will be treated post-op, whether it's going to be ICU or HDU or in the ward. All those will help to reduce anxiety and stress. So we know that anxiety and stress in the period has a lot of negative effects, like activation of the sympathetic nervous system, increased increased heart rate, increased cardiac events. All that will be reduced to some extent by to these patients kindly, explain them what is going to happen to them, how they will be looked after, that their pain will be looked after. All that is.
Excuse me, can I interrupt you for a second?
Yeah.
Did you implement all the enhanced recovery protocols to all patients? Now, in this case, we are talking about anterior resection, to all patients who are going anterior resection, or are you going to select your patient who you decide on implementing?
It's a practical issue. Ideally, we do it for all patients.
Right. So even a patient with comorbidities,
may not be all the elements of the enhanced recovery protocol. So, for example, if a patient is diabetic, give him a glucose-containing drink pre-op, but most of the elements of the enhanced recovery protocol should be possible implemented.
Okay, Pramod. Now we were talking about the benefits of enhanced recovery protocol, mainly to reduce the catheter, and by doing that, the hospital stay, early recovery, and early mobilization of this patient. In addition to that, so what is prehabilitation of these patients? Pramod, can you elaborate a little bit about prehabilitation of patients, for example, undergoing anterior resection? Is it similar to enhanced recovery? It is a different concept.
It is a sort of a novel concept where actually the preparation starts much before than what we used to with the enhanced recovery. It involves a multidisciplinary model approach. The objectives are same. It is to reduce post-operative complications and to reduce the hospital stay. So it involves three components, mainly physical, psychological, and nutrition. So those three components are addressed, and thereby what they say is it's like a marathon. You have to do some training. The physiological functioning of the cardiovascular are the main issues, muscle mass. So addressing these three in the physical aspect. So you're training your body to undergo this most difficult, stressful course of undergoing major surgery. So you need to be cardiovascularly and respiratory system, and the muscle mass has to be fit because you're undergoing phase of surgery. So match this the fluid balance, fluid imbalance, the on the effort to counter all these. We are training body much before at the time you undergo surgery. Start about 4 to 6 weeks before surgery, and your basic aiming patients' exercise tolerance, patients that is mainly the respiratory effort and the cardiovascular fitness, and also developing the muscle mass. Found out that the preoperative muscle mass has a positive correlation with the post-operative outcome. If you have mass, phase that available muscle mass, the proteins, and then it affects your respiratory effort, mobility, and recovery phase. So it's mainly targeted towards cardiovascular plus resistant training. So it's like you go to the gym, training plus cardiovascular training to enhance your cardiovascular system, respiratory system, and the muscle mass. Also targeting on nutrition, having a high protein diet to have a build up your muscle mass and to have a protein good so that in the catabolic phase you can, because anyway any patient undergoing a major surgery will go into a catabolic phase and lose protein in the acute phase. So you have a higher muscle mass with a good storage of protein for that, and also so nutritionally and then psychologically as well. So training the patient, making him ready. It's like running a marathon. So you're going to face this major event, and this is what you're going through. So psychologically, the patient also feels that he is involved in this whole process by undergoing prehabilitation for 6 months. So you can do this. This will involve exercise therapists, the anesthetist, and the surgeon to get involved, and a psychologist in some cases where patients will have sort of like body image issues, stomas, or things like that. For those, you can even get the help of, there are psychotherapists in other countries for surgical units. So all of these people get together and train the patient to undergo this stressful event.
Now, Pramod, even in enhanced recovery protocols, they address nutrition and psychological aspects of the patient, or prepare the patient psychologically and nutritionally. And which is new for the rehabilitation is cardiovascular, respiratory, and building muscle mass. Now, anyway, we even in the past we advise patients to do deep breathing and incentive spirometry and walking around a kilometer a day before surgery. But does it sort of is there any other specific exercises we recommend for a fit patient undergoing anterior resection, for example? Is it just walking or sort of something more than that for these patients?
It is a combination of cardiovascular and resistant training for muscle build-up. And if you're talking about specific surgeries like anterior, it will be also involving the pelvic musculature as well, training your pelvic muscles so that your post-operative will be improved with pelvic exercises. So it's mainly a combination of, those days we used to ask the patient to run or walk, but now it's about resistant training, adding resistant training under supervision so that you build up muscles. Muscle build-up is the new concept, what you call sarcopenia, has come into play. This is mainly in cancer patients as well. When you have a higher muscle, have seen that post-operative outcome and the survival afterwards is much improved. And it is the biggest issue with these patients who undergo major surgery because especially with regard to mobility and the loss of muscle mass which happens afterwards. So the new trend, the new addition, I would say, is the objective resistant training and also the speed training pelvic muscles and so on.
Okay.
Sumudhu, to add on to what Pramod said, Pramod spoke about sarcopenia, and also frailty. The concept of frailty is in this perioperative context, it means a reduction of the physiological results. Right? She is associated with comorbidity like cirrhosis or advanced diabetes, cardiac failure. So that also affects outcome. We assess the severity of frailty, and also so adds on to this rehabilitation. You can identify high-risk patients who are frail and put them on a specialized program, like something similar to what Pramod said.
And also, I think the new addition is now we have these objective measurements of frailty, of sarcopenia, and also the CPET, leading up to assessing the patient's exercise tolerance and the functionality, isn't it?
Yeah. So assessing cardiovascular is the routine and in our pre-op assessment, whether you can climb 2 flights of steps. So 2 flights of steps is equal to about 4 METs. 4 METs is 4 metabolic, which is like the base minimum fitness that you require to go through major surgery with acceptable risk. So if a patient can climb 2 flights of steps without panting, without getting chest pain or palpitations, and the patient is less likely to have a adverse perioperative event.
So, yeah.
So, like Pramod said, cardiopulmonary exercise testing is an form of that.
How implement these things in a patient, for example, undergoing anterior resection? Now, okay, we take psychological rehabilitation and neural rehabilitation and cardiovascular and muscle mass build-up. So how do we now, these are the objects, how do we objectively implement these things in a patient undergoing anterior resection?
Yeah. So with regards to nutrition, I think involvement of a nutrition is important here. To be tough depends on the initial assessment of patients. Some patients might need additional protein levels. Some patients might need reduction of weight. It's not about just gaining weight. It's about having the correct body contour to for a healthy adult. So some patients are reducing weight and building muscle. Some patients might need gain weight and increasing the muscle to do you need assessment, and then on patients startup, as I showed, there are different ways assessing this muscle mass, and so in our level and in research level it's different, but especially in these nutritionists have usually these hand grip strength, lower limb muscles. They have sit-ups and 6-minute walk, those assessments to assess a patient muscle
walk. If I can just butt in, 6-minute walk test to test a screen test, right? It's for patients. If that's a very objective test. If the patient cannot walk more than 300 meters in 6 minutes, that means the patient is probably going to that well in the perioperative period. It means cardiorespiratory reserves are reduced. It's due to osteoarthritis disease. Means that this cardiorespiratory system need to be optimized.
And if we have a, I think that most objective measurement of the cardiopulmonary activity. So after nutritionist will take care what sort of required. Patients might need to cut down carbs and proteins, fats. Patients might need weight gain, so they add both carbohydrates, proteins, so on. So plan we are in our don't have a that is our main focus, but it should be, because if you do not give carbohydrates along with these way, you can't, for a patient who was just not resistant training, you cannot start altogether a very intensive training program at once. So these need to be done to supervision. That's why you need about a 6-week, ideally a 6-week time window to do this. So it's there is a dilemma in cancer patients. It is advisable to pay the surgery, but now there are big muscle training with a biofeedback therapist. Will assess the initial of the sphincter mechanism and the pelvic muscles, and then like the pelvic squeeze, and sometimes the biofeedback therapist have these weights also for females, especially to hold in the vagina and all. So to strengthen the pelvic muscle mass, because that improves the continence. And also psychologically, the main objective in this sort of a patient is to convince them and prepare them for a storm. So will involve marking the storm, some wearing the stoma bag, even before surgery for a few weeks, you get patients to wear them. You get an ostomate who has ostomy to come and talk to them and convince them that it is not that difficult to have a stoma, or the experience, share that experience with the anxiety that the patient has with regard to this, and also body image interest. Most of the patients can be made by the stoma catheter. You need to understand it. The protocol is not a strict, sort of a strict rule like the CPR that you need to follow. But you need to select which ones you can apply patient and which ones the patient needs, and select appropriately.
Right, thank you. Bhagya, now you said sort of you give glucose for surgery. When do you glucose, and how much glucose?
Recommend complex carbohydrates 2 hours before surgery. So that's the last clear liquid that your patient will take before surgery. So
How about
currently, yeah, so you have to be careful with diabetic patients. We will be monitoring blood glucose levels, treating them with insulin if they're hyperglycemic, but the recommendations are not very clear about giving this glucose into diabetic patients 2 hours before. Because you don't want to become hyperglycemic intraoperatively, because these patients are likely to become hyperglycemic anyway because of the surgical stress response. So your glycemic control is likely might go out of control, or it might be difficult to control the blood glucose levels drop if 50 grams of glucose 2 hours before. So I think we need to be careful in using this glucose loading or carbohydrate loading in diabetics.
Okay.
Shall we discuss a bit more about preoperative or other apart from fluid balance, or shall we move to the next step? There are a few things, if you want, we can discuss.
Another question now. How
Clinically, how do you assess the patient's hydration state before the operation? So you go by urine output, that's for sure. Are there any other physical signs you're looking for from practical point of view?
Yeah, history is important. So, has this patient been on bowel prep? Has this patient been vomiting, having diarrhea pre-op? Is this patient feeling thirsty? Is this patient's blood sugars out of control? Is he having hypoturic? All those would indicate you that this patient is likely to have difficulties with fluid balance intra and post-op, and he might even need additional time or additional volumes of fluid pre-op to resuscitate. So history is very important. Yeah, history is important. Then the examination. There is an echo.
Yeah.
Examination findings would add on to that, right? The hydration status, the mucous membranes, the pulse rate, blood pressure, capillary refill time, whether it is cold or not, whether the patient has postural hypotension. The patient, each time the patient tries to get up from bed, if he is dizzy. So all those would indicate that the patient is hypovolemic. And then the urine output. But urine output, you have to be a little careful because patients who are diabetic, who have glycosuria, or patients on diuretics, patients with kidney disease, you can't rely on urine output as an indicator of volume status. But if you put all this together, then you can get a reasonable idea of whether the patient is hypovolemic or hypervolemic, or ideally you.
Yeah. Since we are discussing about preoperative preparation, what about the antihypertensives and antidiabetics before the surgery? How do you stop it and when do you stop it?
So antihypertensives should be continued in the perioperative period, except ACE inhibitors and angiotensin receptor blockers, because patients on angiotensin receptor blockers and ACE inhibitors can become severely hypotensive during surgery, and it's sometimes very difficult to restore blood pressures. Patients on beta blockers should be continued on beta blockers. Target heart rate is about 60 per minute. You should not start patients on beta blockers just before surgery. At least they should be on because for at least 1 to 2 weeks before surgery if you're going to. Not possible at least 7 days before surgery. The clopidogrel should be stopped. Then
diabetic drugs.
Anti-diabetic drugs. Patients on insulin should continue with insulin. It's easier to control them on solid insulin because the half-life is short. Patients on oral hypoglycemics depends on whether you can on oral intake immediate post-op. If the patient is having a minor surgery like a hernia repair, stopping oral hypoglycemics and restarting post-op creates complications like patient control might get used. So those patients can continue hypoglycemics pre-op, post. The problem, sorry.
Even the morning dose, you have to give antihypertensive.
Should be given except angiotensin blockers. They should be stopped at least 24 hours before. And if their blood pressure increases, then you might have them on a different antihypertensive like a calcium channel block, nifedipine slow release, or a similar drug to control their blood pressure without using inhibitors and angiotensin blockers. Oral hypoglycemics, like I said, should you can continue them if the patient is likely to be able to start oral intake immediate post-op. If that is not possible, then to stop the oral hypoglycemics pre. We accept hyperglycemia rather than hypoglycemia because there is a lot of evidence coming through shows that glycemic control increases mortality, especially in septic patients. So we accept slightly higher blood glucose levels, even up to 200 milliliter, than having the patient becoming hypoglycemic. If you stop, the insulin can be controlled post-stop, different algorithms for insulin therapy, but based on the capillary blood glucose levels. We try to achieve, the target is 140 to 180 milligrams per deciliter blood glucose.
Is the sliding scale, is it acceptable?
The problem with the sliding scale is, say patient's blood glucose is 200. According to your calculation, you need to give 10 units of insulin. Then the next time you measure, the patient is hypoglycemic. Then you stop the insulin. Then the third reading, patient is again hypoglycemic. So it becomes, this glycemic control becomes the blood sugar levels fluctuating quite a lot when you put them on a slide. It's better to put them on a fixed dose or a continuous infusion and titrate that dose slightly rather than trying to chase a blood glucose.
So that's obsolete practice, isn't it?
Sliding scale is, I would say, not very acceptable.
So, what is the current recommendation for pre-operative in anemic patients? Awaiting still.
So, why do you give blood? Why do you give red cell transfusions?
To increase the oxygen.
To increase oxygen delivery to the tissue. So, say you take a patient who's chronically anemic, they have compensatory mechanisms which ensure oxygen delivery. Like, for example, you take a T plucker who works from morning till evening. So they have alcohol, all that, but they work from 4 o'clock in the morning. So if you bring one of those patients to our hospital, they'll get a blood transfusion because they are going in the perioperative process is whether these patients oxygen delivery or not. All products carry side effects, and just giving a blood product you can't automatically increase oxygen delivery, right? Stored blood will have lower levels of 2-3 dpg, so your oxygen delivery is going to be impaired. Just giving is not going to help. So one is you need to test whether this patient has cardiorespiratory disease, because if we discussed this earlier, the oxygen depends on cardiac hemoglobin and saturation. And so if you have a drop in input, a patient who hemoglobin saturation might be able to still give adequate oxygen. So if a patient has cardiac disease and respiratory disease, right, this patient probably needs a higher hemoglobin in the preoperative period. Whereas a patient who doesn't have cardiorespiratory disease, who can increase the cardiac output, maintain normal saturation, and therefore maintain normal oxygen to tissues, can tolerate low hemoglobins, even 1 grams per day. So the guideline is the low one, the upper limit is 9. It has hemoglobin upper limit of hemoglobin concentration of 9. Even if they have cardiorespiratory disease, they should be able to manage. So if the patient has a hemoglobin less than 7, even without cardiorespiratory disease, they will probably need a blood transfusion. Between 7 and 9, decision to choose or not depends on whether the patient has respiratory or not. In a central line, you can do blood gas from the central venous line and assess the central venous saturation, which is indicator of oxygen adequacy of oxygen delivery to tissue. Patient whose marginal 0.5 hemoglobin, but the patient is bleeding, trying to avoid blood transfusions, your intravenous oxygen saturation might help you to make that decision. If the intravenous oxygen saturation is normal, say 7, that means that the patient is already getting adequate amounts of tissue delivered to the tissues. So, patient will not get an additional benefit by having a blood transfusion to increase hemoglobin to 10 or 11, right? So that's, I think, how we decide whether to transfuse patients or not.
Thanks. So we've been discussing not only fluid balance, preoperative, discussing preoperative preparation, discuss about how to balance the fluid before the surgery, how to optimize rehabilitation. We talked about the concepts of rehabilitation, ERAS protocol, and then how you manage the medications before the surgery, and we also discussed about blood transfusions. Shall we just let them ask any questions if there are any questions before moving to the next step, next stage? You all have any
just one more point to expand on what Kaushika said. Again, not we are moving towards goal-directed therapy or hemodynamic monitoring management as well as blood products. Right? So unless there is definite evidence for the need for a blood product, we do not use blood products because of the problems with blood products as well as the shortage of blood products. So if a patient has a platelet count of 90,000, we will still not transfuse blood platelets to this patient unless he has other of to suggest that he's bleeding or he's at risk of bleeding, right? So we go directly for hemodynamic blood.
Yeah. Are there any questions?
Rohan, are you recording this thing? Somebody has asked.
Arun, I can't record because I'm not the host today because I got locked. I think I tried to record, but I can't record.
Who's the host then?
No host, I think.
Host has become hostile.
Are there any questions from students? They have put some questions, but we have to ask from the people rather than just typing.
Yeah, somebody has asked about the clopidogrel.
Don't answer, or I will let them ask the questions.
Sir, one question, sir.
They should have some courage to ask.
Sir, one question, sir.
Yeah.
Sir, regarding the preoperative fluid management, sir, like the patients who are in chronically congested states like CKD and cirrhosis, how we like Bhagya sir said that we can if they get us in the people, they can drink free. As that apply to the patients who are cirrhosis and CKD too, sir?
CKD is a bit difficult, and even if they are not having surgery, they have fluid restrictions, right? The nephrologist would have advised them, say 2.5 liters a day or whatever. They would be on that restricted fluid regime, and that can be continued as long as they don't have abnormal losses. Right? If a patient with CKD has bowel preparation, then we need to factor that in and get that patient to take more fluid orally. And wherever possible, you have to try to get patients to take orally rather than giving intravenous, because it's very difficult to overload a patient by giving oral fluid. Right? The patient will drink only what he requires. But the moment you start giving intravenous fluid, the patient has no control over that. Patient's body doesn't have any control over the fluid, and most of this fluid ends up in the interstitial compartment. So wherever possible, get these patients to take orally and stick to the limits, and also use additional fluids to account for abnormal losses. It's the same with cirrhotics. Cirrhotics also, quite often they are fluid restricted because of ascites. They might be, but they might also be on diuretics, which means that they are losing fluid. Unexpected amounts of fluid will be lost in urine. So you can't say that the urine loss is only 1 ml per kilogram per hour. Then we will have to give extra fluid ideally in the form of oral fluid.
Answer one other question, sir. What about the pediatric population, like breastfeeding infants, and their operative fluids management and the post-op feeding, sir? Starting of the post-op feeding, sir?
Yeah, so patients who are on milk, if it's formula milk is considered as a solid, right? So we stop formula milk at 6 hours. Slightly more acceptable can go on till 4 hours, and clear liquids up to 2 hours. Start fluids post-op. Babies who are on breast milk, as they are awake and crying after anesthesia, they've recovered fully after anesthesia, they should be, unless there is a surgical contraindication, they should be fed, breastfed. Right? Because again, if we try to control their fluids, there's a possibility that we might overload them or dehydrate. So wherever possible, get them to feed. If they are, get them back on the breast.
I've got a question to ask from Sums actually. When you talk about the ERAS protocols, one of the essential criteria is to have enteral feeding, early enteral feeding. So when you do a bowel anastomosis, so what about giving fluids and the other nutrients enterally? Are you still more conservative, or you do start on the just on the first day itself?
We start from the first day onwards. Good old days, we didn't feed them for 5 days. I can remember when I was a house officer, we were strictly instructed not to feed for 5 days after bowel anastomosis. And the reasons were ileus due to surgery, as well as takes about 5 days to heal the anastomosis. Now, ileus will recover sooner than that, and the various parts of the bowels recover in different timings. The best way to sort of guide that is not bowel sounds, but a test feed. You don't have to wait for bowel sounds to feed them. In fact, even mastication itself, if you chew a chewing gum, that will promote early bowel function. So some type of a stimulus is needed to restart bowel function. So that is why we feed them, but in small amount. And as they tolerate, we can gradually increase. So we do start from day one and gradually increase as they tolerate. And one other thing is, it is a widely accepted thing in our culture to have chewing gum, but that will also promote early gut function.
Right. So I think feeding enterally doesn't increase blood flow, reduce translocation, improve healing.
Of course. If you start feeding, whether you eat or not, there will be saliva, gastric secretion, bile, pancreatic secretion. There is more than 2-3 liters of fluid entering into the small bowel. But giving some fluid, adding another 20 cc per hour, 30 cc per hour, will not going to do anything but dilute it. And that will help to sort of increase gut blood supply, reduce gut translocation, as he said, and also sort of it enhance sort of gut healing as well now.
Thank you.
So another question, sir. What about some warfarin?
Stopping warfarin before surgery?
Yes, sir.
Okay, so you first need to find out why the patient is on warfarin. For example, if a patient is on warfarin for he's got a prosthetic valve, we have to be very careful when we stop warfarin, right? Just to talk to the, say, if the when the patient is on warfarin, is to talk to the cardiologist as well as the hematologist and come up with a plan which you can all agree on. The surgeon, anesthetist, hematologist, cardiologist, everybody agrees that okay, this patient, we can stop the warfarin at this point and bridges anticoagulation with something else like heparin. So that needs to be agreed on. But generally, you can stop warfarin 3 days before surgery, and once and start him on heparin because heparin has a shorter half-life. And heparin 4 to 6 hours before. I'm talking about unfractionated heparin. Stop heparin 4 to 6 hours before surgery. Proceed with surgery and restart. The patient can start take orally. You can start the warfarin and the heparin. And once the INR reaches the therapeutic level, stop the heparin and continue with the warfarin.
Thank you, sir. So, is for preoperative anxiolytics?
No, anxiolytics are not recommended now unless the patient has been on anxiolytics long term, because anxiolytics can cause a lot of post-op recoveries, bed, some especially elderly patients can become very, very drowsy and even hypoventilate overnight. You give them diazepam. There used to be it was traditionally prescribed diazepam 10 milligrams nocte, right? You give diazepam 10 milligrams to a 80-year-old man, he probably might be dead in the morning because he stopped breathing, right? So you have to be very careful. These patients have a lot of comorbidity. I can't reference, but there was one study which showed that house officer having speaking to a patient very kindly with a lot of patients, answering all the questions. The anxiolytic effect is as good as giving a benzodiazepine. So talking to patients, laying their fears, explaining the procedure and what's going to happen on the day of surgery is as good or even maybe better because it doesn't have side effects than giving anxiolytics. Anxiolytics will have a place in patients who are very anxious and their blood pressure is out of control, their ischemic heart disease is resurfacing. Then you might give a anxiolytic, but again, short-acting anxiolytic, maybe on the day of surgery in the morning, you might give a small dose of short-acting anxiolytic.
Thank you, sir.
So, excuse me, sir. I have one question, sir. Sir, you mentioned that best way to rehydrate is through giving orally, sir.
Yeah.
But when we are giving IV fluids, sir, we are directly giving it to the intravascular compartment. Why oral is better?
So then we should not have a mouth, but we should have direct access to the intravenous compartment from birth, right? So you have a mouth and a GI tract because that's a physiological route for fluids. If you give IV fluids, one thing is the patient is not going to control the IV fluids. We are going to control the IV fluids. So we have lots of various ways of calculating IV fluids, deciding on the type of IV fluids. We may be wrong. And the IV fluids that we give, most of it, crystalloids, if you go back to your physiology and think of the distribution of fluids, intravenous fluids, crystalloids, if you give 1000 milliliters, only 25% will remain in the intravascular compartment after 20-30 minutes, right? So if you give 1000 milliliters of fluid, you're going to have 750 milliliters of interstitial fluid. So you're going to cause a lot of edema. Whereas if you take orally, you might not take 1000 milliliters of fluid. You might take 50, 60 milliliters of fluid at a time, and intravascular compartment, interstitial compartment, as well as the intercellular compartment in a more physiological. So wherever possible, you try to give oral fluid because it's good for the gut and good for the it causes a more physiological distribution of fluid.
So I got two questions actually. So one is what about pre-op analgesia, sir? So I saw an article on gabapentin and paracetamol. Are there any other methods of pre-op analgesia, sir?
Depends. If a patient is in pain, if a patient is in pain, say a patient has a ischemic limb and is awaiting amputation, his pain needs to be controlled. The patient is in, there's a patient in the ward now with ampullary carcinoma who gets pain, intermittently severe pain. So that pain needs to be controlled. So how you control it depends on, yeah. Can't hear.
No, I think that's not a question. It's some.
Okay. So definitely needs to be covered. Then you need to decide how you are going to control it. If it's severe pain like ischemic limb, you might even place an epidural, because epidural analgesia will be useful in the pre-op, in post-op period. There is a patient who has less severe pain, we might, if he's able to take orally, he might have some oral paracetamol or oral Panadine. More severe pain, slightly difficult to control, we might put them on intravenous paracetamol or parenteral morphine, like subcut morphine. So different options. We have different options, but there is a concept of preemptive analgesia, where you give good analgesia before the surgeon makes an incision, because there is evidence that even the pain from the incision before good analgesia is achieved can sometimes lead to development of chronic pain because of alterations in the neural circuits. So so that's why epidurals and spinals are useful, because patient's pain pathways are blocked before the surgeon makes an incision. So the chance of developing chronic pain is less.
Okay, sir. And the other thing is, like, are there any is it the same for like people with high risk of aspiration, like diabetes, mellitus, pregnant women, obese? Is the same like regime, or are there any differences or any antiemetics we use, sir?
Yeah, so pre-op assessment becomes very important, right? Patients with hiatus hernia, reflux, those are patients who are at higher risk of aspiration. We might put them, we will keep them, the fasting duration is the same, right? But we might, in addition, use drugs like metoclopramide, which are prokinetics, increase low esophageal sphincter tone, reduce the gastric outlet sphincter tone, and promote gastric emptying. We might use drugs like that, and we might also modify the way we induce anesthesia and intubate patients. We use a technique called rapid sequence induction with cricoid pressure and a different combination of drugs to reduce aspiration. So pre-op assessment and identifying of patients at risk of aspiration becomes very important.
Thank you, sir.
Sir, one question.
Yeah.
Sir, one question, sir. Like, do any target BP values and the like values on the day of surgery, sir? Like, if the patient has more than this, we should not go for surgery.
Yeah, so most of the time, patients' blood pressures will increase on the day of surgery. In the morning, you will find that the blood pressures increase. That's because of the anxiety. So that's why pre-op blood pressure control becomes important. Right? But generally, even if the patient has a blood pressure of say 180, 100 on the day of surgery, we still accept it, bring the patient to theater and give a small dose of anxiolytic on table, because we have control of the airway, we can monitor the patient, and then let the blood pressure settle and then induce anesthesia. It's dangerous to induce anesthesia in patients blood pressure is out of control, because they can develop an intracerebral bleed or have an acute cardiac coronary event because of this uncontrolled hypertension. So you have to be sure that it is not preoperatively poorly controlled hypertension that is causing the high blood pressure, but just anxiety about surgery on the day of surgery. So the target is 140, 90. 140, 90 is the target blood pressure in most patients. But a single reading of 160, 100, or 180, 100 on the table doesn't mean that we are going to postpone surgery.
Is that the same for the glycemic control, sir?
Yes, glycemic control target is to have a blood sugar between 140, capillary blood sugar between 140 to 180 milligrams per deciliter at induction and in the perioperative period.
Thank you very much, sir.
Excuse me, sir. Can you tell about the antibiotic before surgery?
Antibiotic?
It must be asking what
surgeries?
Yeah. So, Pramod, you want to talk about prophylactics, prophylactic antibiotics?
So we were talking about anterior resection, so which involves mechanical bowel preparation. So at the moment, the evidence supports mechanical bowel preparation for to reduce both anastomotic leakage plus surgical site infection. But still, it's a surgeon's preference. There is no hard and fast rule. There are surgeons who operate without mechanical bowel preparation when you're preparing a patient for especially anterior resection. They just give a enema on the morning of the surgery and go ahead. And also there is now evidence coming up for preoperative oral antibiotics. Oral antibiotics plus mechanical bowel preparation. That is, you give the clean prep as you prepare for a colonoscopy, as we discussed the other day, the split dose treatment of clean prep, and along with that you add oral antibiotics. So the evidence is there for the use of metronidazole and neomycin or erythromycin in different trials. The recent largest European audit was for neomycin plus flagyl. So they give sort of like 1 gram of metronidazole and 2 grams of neomycin on the day before surgery. But in Sri Lanka, we do not have neomycin available. So what we do is we give erythromycin. There is currently a trial trying out rifampicin as a substitute for neomycin. Data is not yet out, but whatever, when you give an oral antibiotic on the previous day with mechanical bowel preparation, there's a significant improvement of in surgical site infection rates. And also, they say there's a reduced rate of anastomotic leakage in left-sided colon surgery. So we currently in our unit, we practice both mechanical bowel preparation and oral antibiotics on the previous day.
Thank you.
That's all. Any other question? I think Pramod, Bhagya, yeah, almost like 10:30.
Yeah.
We'll stop from pre-op today, rather than without moving to the in perioperative and post-operative period. If you allow any questions, ask now. Otherwise, we'll stop for today.
So, what is the pathway, like the physiological carbohydrate loading before surgery?
Yeah. So you know that with fasting, the body initially uses up glucose and then switches to an anabolic mode, catabolic mode, where proteins and adipose tissue is mobilized to generate energy. So when you load with carbohydrates, you avoid pushing the body into a catabolic phase, and if the body is already in catabolic phase, it will switch back into an anabolic phase. So you can prevent the breakdown of in tissues in the patient's body. And like Pramod said earlier, we try to preserve this protein because it's important that the patient is able to take deep breaths, cough, mobilize post-op, and for lots of other reasons. Right? That's one way. The other reason is that when you give a carbohydrate load, the the stress hormones which are secreted by the body in the perioperative period, like cortisol and glycogen, glucagon, and various other counter-regulatory hormones which tend to increase blood glucose levels, their levels are reduced by this glucose load. So the sensitivity of the body to insulin is increased. Right? So again, this promotes, so insulin is an anabolic hormone, so it promotes wound healing, the stress response, standard, components of the stress response like salt and water retention mediated by angiotensin, all that is reduced, but principally the insulin resistance of the tissues is reduced when you load the patient carbohydrate before serving.
Thank you, sir.
Excuse me, sir. Can you explain the term of fluid challenge? Is it thus in hypervolemic stage we are giving bolus? Is that the term refined that, or is there any steps or pathophysiology for that, sir?
Yeah, so fluid challenge. Okay, so we discussed earlier that the reason we try to maintain intravascular volume is intravascular volume or cardiac output is one of the main factors which influence tissue oxygen delivery, right? So cardiac output is stroke volume into heart rate, and stroke volume depends on preload, contractility, and afterload. So here we are trying to identify patients whose tissue oxygen delivery is reduced because of reduced cardiac output, because of reduced stroke volume, because of hypovolemia, right? Is that clear? So fluid challenges are used to identify patients who have reduced oxygen delivery to tissues because they have reduced preload. Right? We say that those patients are fluid responsive patients. If you want to improve tissue oxygen delivery, you need to improve their cardiac output by improving volume, by improving the preload, right? But there are people who are not fluid to those patients, they will be worse because they are on the descending Frank-Starling curve. Right? So you give a small volume of fluid and see how the patient responds. If the patient is on the ascending part of the Frank-Starling curve, is by giving a fluid bolus or fluid challenge, you're increasing his preload, and his stroke volume and cardiac output should improve. But if he's on the descending part of the Frank-Starling curve, a fluid challenge will push him down further on this descending limb. His stroke volume and cardiac output will drop, and his tissue oxygen delivery will reduce. So that is the basis of giving a fluid challenge. If a patient is fluid responsive, you give a fluid challenge. Patient's condition improves. His venous pressure will increase, his blood pressure will increase slightly. If he is severely tachycardic, his heart rate might come down, his urine output might improve. Then you know that this patient is fluid responsive, and then you can give another fluid. Right? But if the patient, you give a fluid challenge and the patient becomes tachypneic, you find that he has developed bilateral fine crepes in the lungs, his saturation has dropped, and he's clinically worse off, then you know that this patient is not fluid responsive. If you want to increase oxygen delivery, you need to do something else, not give fluid, right? So that is the basis of giving a fluid challenge. You're trying to differentiate patients who are fluid responsive from who are not fluid responsive. Is that clear? That's the question.
Yes, sir. So it is a diagnostic and a therapeutic procedure also.
Yeah, absolutely.
Okay, thank you.
Sir mentioned about the ARDS, sir. Is the ARD, sir?
Yeah. So ARDS is acute respiratory distress syndrome, right? ARDS causes non-cardiogenic pulmonary edema, where the pulmonary capillary hydrostatic pressures are normal, but there is increased leakage of fluid into the pulmonary parenchyma because of destruction of the alveolar capillary membrane, or the cells of the alveoli and the capillaries. Inhalation injury, it's probably a combination of heat injury, toxins, and the inflammatory response to the burn. All these will contribute to this contribute to the destruction of the alveolar capillary membrane and leakage of fluid into the alveoli, leading to ARDS.
Thank you very much, sir.
Yeah, I think from 10:30 we'll stop Bhagya.
Yeah, okay.
Yeah, so we'll continue the next day. So I think that's it for today.
Okay.
Thank you, sir.
Thank you, sir.
Okay, bye.
Thank you, sir.
Thank you very much.